final part of the COPD lecture. I'm actually going to finish off from where I started yesterday. From where I ended yesterday when I ran out of space. And then I aim to discuss therapies that are used in COPD, the medical therapies, and how therapy planning really is done or managed based on the GOLD diagnostic staging system. I'm also going to discuss the end-of-life care, which obviously is part of the management of COPD. And I will also obviously talk about oxygen therapy as well. So to begin with, like if I take it back from where we were yesterday, I was discussing how someone with emphysema will develop Ebola based on, when the loss of the septa between the alveolar walls and the loss of the alveolar duct. So when this happens, we have what we call air trapping. However, what's important to remember is that in this situation here, as oxygen comes in, during say ventilation, oxygen will come in. However, because there is no functionality, this is an alveolar that has lost its elasticity recoil. It has also enlarged in size. And it also, has lost things like surfactant, which was, giving it that structural support to maintain the pressure and that elasticity recoil. So we now have an alveolar that has a very low pressure anywhere, indeed. So as that happens, as one breathes in that situation, what happens is they start trapping in air, and as they trap air, if we were to remember, this is the tidal volume and this is the forced expiratory volume, and this is the residual volume which always remains in the lung. So these patients in this situation end up increasing their total lung capacity, and they do that by retaining much more air, which means that the residual volume actually increases. And if it says the residual volume increases, the tidal volume will decrease. So in a way, this is how I think about it anyway, to make life a bit easier for myself, that there is an upward shift. So the tidal volume, instead of being here, say if this was the first tidal volume in a if that was the first residual volume and the first tidal volume in a normal person, and this is obviously the forced expiratory volume there, what they can, expire if forced to. So this is the tidal volume. If this was the first tidal volume of a normal, a person without pathology. So as pathology occurs in that situation, air trapping, the way I think about it is that it enlarges the residual volume. So you have a residual volume that shifts upwards. I think of it as an upward shift. I know it's a wrong way to think of it, but it makes life so much easier. And as that upward shift then allows me to then obviously remember to reduce the tidal volume. So as tidal volume reduces and residual volume increases, the total lung capacity will increase as well. So an increase in total lung capacity due to the enlargement of the alveolar means that the pressure has been reduced. So if we're to remember, just from basic physiology of the respiratory system, when a diaphragm is flattened, there is increased pressure, and increased, sorry, there is yes, there is increased volume, like increased capacity, and there is low pressure. However, when the diaphragm when you reduce the volume, the pressure increases. So if we, if we take it from there, that as we increase the volume, the pressure reduces, and the pressure we're talking about is obviously the oxygen partial pressure, which normal is 8 kilopascals. So I think it's also, we also have it in milliliters per mercury. So that the normal oxygen pressure reduces. So now we will have people who have, I think I can actually safely erase this. So we will have people who have low oxygen pressure, and obviously low oxygen pressure means that there is high CO2 pressure, and that state of being hypercapnic then activates the central respiratory center, activates the central, I don't know what I said, I should have just said, activate the central center, respiratory center, and sort of activation of the respiratory center obviously then forces one to breathe more forcefully, so it increases the force of breathing. That's inhalation and exhalation in a way, as a means of trying to get rid of the carbon dioxide and increase the partial pressure of oxygen. Usually when people increase their force of breathing, then we can see that they are making the respiratory effort is increased, rest effort is increased, and usually they can get enough oxygen to sustain them, as in, although it will never normalize, the oxygen, the carbon dioxide gets reduced enough to sustain that that person in that situation whereby they are just breathing really heavy, whereby they get low oxygen, breathe heavy, sort of normalize. So that cycle goes on and on and on. And when you see patients like this, the defining feature that we normally use is, we call them the pink puffers, because of that respiratory effort they are making in order to breathe. So they are increased respiratory rate, increased force of breathing to actually just get the carbon dioxide out and get oxygen in to maintain the metabolic needs of the body. So from this situation, if they can manage this, then obviously they're unwell, but they are somewhat managing really. However, if this fails, if that sustained carbon dioxide goes on and on and on, what happens is that the respiratory center becomes insensitive to hypercapnia. Whereas really, normally, the respiratory center is highly sensitive to hypercapnia. So if it loses that that high sensitivity to hypercapnia, then it becomes much more insensitive to hypercapnia. And what we find is that the patient then loses their CO2 respiratory drive, and they start retaining CO2. Well, they are retaining CO2 anyway, but that retained CO2 is no longer effective in stimulating the respiratory drive. Instead, they then start to rely heavily on hypoxemia, on that state of being hypoxemic. And hypoxemia is the one that then drives being hypoxic then comes into drive their respiratory drive, and this is how they sustain their lives. So these patients here who heavily rely on the hypoxemia drive are normally present as, because of the low oxygen that they have, the body will kick in the compensation mechanisms that we learned about in cardiology. So the compensatory mechanisms such as fluid retention. I'll actually write this at the top there. So then the body will stimulate the compensatory mechanisms such as fluid retention in order to increase the volume of blood. So the increase in volume of blood, remember these are people, these are normal volumic people. They have not lost any blood at all. So this is just an extra blood that they really do not need. So that increase in the volume of blood really leads to edema and fluid overload. And really, fluid overload will it presents as right-sided heart failure or right ventricular hypertrophy. Before we actually get to heart failure, so it will be right ventricular hypertrophy. Obviously, then will eventually, if it's left untreated, will eventually lead to heart failure. So, and we call this core pulmonary. I need more spice. Pulmonary. And then the other mechanism that's stimulated is erythrocytosis. So they will also have erythrocytosis, whereby the production of red blood cells is increased. And the increase in the production of red blood cells eventually leads to polycythemia. And this obviously also presents complications such as strokes, DVTs, sorry, not DVTs, definitely not DVTs. Not DVTs, DVTs. Also, a pulmonary embolism, and pulmonary hypertension. So it actually then, the person becomes at a risk of increasing diseases, conditions such as these, which also obviously then worsen the condition. Polycythemia can be managed with venesections. So again, these people are, the people who have pulmonary hypertension. They are retaining a lot of fluid. They are mostly cyanized, particularly centrally, and they are called blue. They present as blue bloaters, who are very different from the pink puffers, who still have the hypercapnic respiratory drive, but they have to put in a lot of effort in order to breathe. So the blue bloaters are quite important when it comes to treatment, because if we were to give them oxygen, I think I mentioned this at the beginning of the respiratory lecture talks. So if we were to give them oxygen, it has to be to recognize that hypoxemia is their only respiratory drive. So if that was to be corrected, they would lose the respiratory drive and they would go into resp failure. So instead, it is better to give them enough oxygen, but to leave them a bit, with low pressure of oxygen, so that they can still have a respiratory drive in order to avoid respiratory failure. And this is the most important consideration really when managing blue bloaters, because although they are not really gasping for air and they sit silently and look as though correcting hypoxemia is the way forward, it should be avoided. 100% correction should be avoided. Their hypoxemia should be maintained at I've forgotten the percentages, but their oxygen saturation levels should be maintained at a low normal oxygenation, so that they can still have their drive for respiration. So this is how chronic bronchitis from a sustained chronic inflammation and emphysema, both the central ancinar emphysema and the pancentric emphysema, and the irregular emphysema and the septal emphysema, all works together to cause the clinical features of COPD and the complications that then occur. So in terms of managing COPD, we must remember that most of these patients are smokers. So really in mild, if we were to say, start there with mild, progressing to severe, we'll find that in mild cases, it is always better to start with advice on smoking cessation, so if the patient can be helped to stop smoking, then fantastic, then lung damage will stop occurring, and that will be managed, and that will be a job well done. However, the inflammatory process and the pathogenesis that has already occurred, such as the reduction in the obstructive airway disease, has to be managed. So initially they will be given a short-acting bronchodilator short-acting bronchodilator to be given as required. Usually some people might want to have it before they take exercise, or they might want to take it after exercise, depending on their symptoms and how, say if they really feel breathless after exertion, then they might want to take it before to relieve that, well, to prevent really, or use it as a reliever afterwards. So short-acting beta agonist work by activating the beta 2 adrenergic receptors, and when these receptors get activated, what they do is they increase calcium reuptake, and then they also increase calcium efflux out of the cell, and then they reduce calcium influx. And the effect of all of this is that there is less calcium, for muscle contraction. So we then have the smooth airway, muscle relaxation, and bronchodilation. Again, the pharmacological effect of how beta adrenergic receptors work, I have it on there, and I think I was just doing the beta 1 for cardiac force of contraction, but then beta 2 just oppose everything that the beta 1 are doing. But I'm not going to go into it. I think it's easier to go into it when one does pharmacology, so I'll leave it alone for now. But it all has to do with the phosphorylation via the protein kinases. So the short-acting, one example is a common example is salbutamol. And then we also have the long-acting, which is shortened for SABA. And then they are given, as one becomes moderate, and the SABA as required is no longer really working. So you can give a long-acting beta agonist, antagonists are for cardiology. These are agonists, they activate the receptor instead of blocking it. So the long-acting ones work exactly the same as the short-acting ones. The only difference is that the short-acting ones, the effect is immediate and it lasts a short time. The effect of long-acting ones is much more long-lasting, and it takes a little while for it to relieve. Oh, I should have left that actually. Bronchodilators. Other forms of bronchodilators that are given are the anticholinergics, and again, all they do is work on the M3 receptors, which are found again on the small airway smooth muscles, and all they do is to block the binding of acetylcholine, and blocking the, normally when acetylcholine binds M3, it results in broncho constriction. So blocking that, the binding of acetylcholine onto its M3 receptor, so the antagonistic effect of that will then cause broncho will then cause bronchodilation. So this is how a quick review of how the M3 receptor antagonist work. The other medication that can be given in terms of bronchodilators, a combinations of therapies. For example, a SABA can be given with an M3 receptor, and you know that then can be used PRN or as a management plan for the COPD, or you can have a SABA and a LABA together. Shall I just say SABA and anticholinergic? A SABA and well, I've said that, sorry. I meant to say a long-acting beta agonist and corticosteroid. And these are used, you know, as we go down the scale for people who are moderate to severe. And then when people become much more severe, they then need all the treatment that, no, before we actually even get that, in these people as well, we have to manage the inflammation. And inflammation is managed with inhaled corticosteroids. So inhaled corticosteroids. And inhaled corticosteroids actually have to be taken daily, or so they have to be taken daily. And the other thing that well, okay, let's get into severe. Severe get all of that. So everything that we have given, they can also be given oral corticosteroids, like I feel as though I can't spell prednisone. So they can also be given a rescue pack of antibiotics, specifically the macrolates are the ones that are used mostly, because people with COPD normally get things like H. influenzae or strep pneumonia or C or M. catarrhalis infections, and I mean they can get things like pseudomonas, but usually these are the infections that they get, and they respond very well to macrolide antibiotics, which just work by inhibiting the S50 subunit of the ribosome, thereby, you know, inhibiting bacteria multiplication. And as people get severe as well, they will need oxygen therapy. so they will need oxygen therapy. And oxygen therapy again is managed via if we're to remember blue blotters, the titration of oxygen has to recognize that they need that hypoxic drive. And the pink puffers as well, the oxygen therapy will be managed based on the patient's actual clinical features and the clinical presentation and the underlying pathogenesis. Again, as people become even more severe, you know, or even before they even become more severe, things like respiratory rehab, where they do exercises to help the respiratory muscles to, you know, to work better, and to also reduce the exertional dyspnea. Are some of the key things that can be done. The other things as well, obviously as people become much more severe in their illness, then you know, it's all about managing symptoms really and trying to get people as comfortable as possible. So another important feature in all of these people are the vaccinations and keeping up to date with vaccination. So all COPD patients need vaccinations, and the vaccinations we talk about are the influenza, the annual influenza, and the pneumococcal vaccination. So they will need them. Obviously the pneumococcal vaccination is usually given to old people who are over the age of 65 years old. However, people with COPD, as with other people with other long-term conditions like asthma, and other people like diabetes who are high-risk patients, do get both of these vaccinations. So in terms of, you know, deciding the treatment, it's actually based on the gold standard, on the gold assessment, which I talked about yesterday. In fact, it's not even the gold, it's the modified one, which is used to guide treatment based on, you know, how high risk a patient is and the number of exacerbations they get annually. So the modified gold, the gold severity assessment tool is used. And yesterday when I was talking about the gold severity assessment, I actually could not remember that this is the global initiative for obstructive lung diseases. It's not the association, it's the initiative for obstructive lung diseases. So now we have discussed the general management the general management and maintenance of people with COPD, including smoking cessation, including the annual vaccinations, the use of bronchodilators, the use of corticosteroids. And I've just realized that I have not talked about one other drug that is used in COPD,